Good afternoon, and thank you for standing by. At this time, all lines will be in listen only until the question and answer portion of the call. At that time, to ask a question, to press star, then 1, and please be sure to record your first and last name. Today's call is being recorded. If you have any objections, you may disconnect at this time. Ms. Davis-Allen, you may now begin.
Thank you. And thank everyone for taking the time this afternoon to join our webinar. The purpose of the webinar today is to overview the audit process, and we have representatives from KPMG, who is the contractor with AHCA for conducting these audits, and we're real excited about their ability to come on and kind of tell us a little bit more about the process, some of the federal perspective of the process, but more importantly, as a provider, how you can prepare yourself at the time of attestation to be prepared if you were to be selected for an audit. For those of you who had some issues signing on, I do apologize. We may have additional people sign on as the call goes on. We are going to be recording this and having it posted on our website at a later date for those who may not be able to join or if you want to be able to refer back to it. But at this time, I'm going to go ahead and turn it over to Chris with KPMG and let him get started because we definitely want to have enough time for any kind of questions and answer any questions that you may have. Chris?
Thanks, Kim, and good morning to everyone, and or good afternoon, and good morning to those on the West Coast. My name is Chris Krepko. I'm a manager with KPMG. We've been working with AHCA for about the past year on doing post-payment audits of the eHR Medicaid Incentive Payment Program. I'm joined today by Sarah Kaiser. She's an associate with KPMG. We're in KPMG's regulatory compliance practice based out of Orlando. If you have been selected for an audit over the past year, you probably had a chance to talk to Ms. Kaiser or one of the representatives from our team. Today we're going to go over, we got about 20 to 30 minutes of prepared remarks, and then we're going to leave some time, 10, 15 minutes for Q&A at the end of the call. Also on the call, we have some members of the AHCA program team for the eHR program, as well as a subcontractor that KPMG uses for these audits. Just to give you a high-level agenda, we're going to to talk about the eHR program nationally, as well as within Florida, to kind of give a perspective of how Florida fits into the national picture. We'll talk about our high-level audit approach. Sarah will go over some details around the audit process and what to expect if you are, in fact, selected for an audit. We'll talk about some best practices and information required for the audit process, both for AIU and MU audits. We'll also talk about where we've been so far in terms of audits and our high-level results to date, what kind of trends we're seeing for program year 11, and any challenges that we've encountered. And then at the end, we'll do a quick recap and open it up for Q&A. I mentioned that we have a subcontractor on the phone. They, as well as some of our program staff, may assist in the Q&A portion of the presentation today. So moving on to the next slide, slide 3. This kind of gives an overview of the national figures around the Medicaid eHR incentive program. And if I could focus your attention to the last column, total program to date. So at the national level, there's been just over 100,000 payments as of April 2013, and it resulted in about almost $2 billion worth of incentive payments just on the Medicaid side. And within Florida, approximately just shy of 6,000 payments as of June, and over $112 million in incentive payments. So you can see the volume is pretty significant here, and it kind of sets the stage on why these post-payment audits are important to make sure that the money was coming down from the feds through the states was handled appropriately. Moving on to slide 4, this kind of gives a graphical picture of where Florida fits into the mix in terms of being one of the top three in terms of payment volume. California, Texas, and Florida are really the top three players here, and this is both Medicare and Medicaid. So Medicare is depicted in the blue bars, and Medicaid is in the red bars. But clearly, you can see that there are some. Florida plays a very important, vital role in the national program. Now let's talk about Florida's audit approach briefly. So at a high-level perspective, the Agency for Healthcare Administration, AHCA, has designed their program to get the funds to the providers quickly yet responsibly. And this is a balance of prepayment verifications through MAPR, through the attestation process, as well as balancing those with post-payment audit activities that we're going to be talking about more today. So there's prepayment, there's system verifications that the MAPR system actually performs. There's prepayment verifications that AHCA program staff perform. There's internal audits conducted by AHCA, and then there's the external auditors, the contract auditors, which is KPMG in this instance. In terms of evaluating and selecting providers for audit, we have worked with AHCA to define a strategy into defining three categories, and that's low, medium, and a high risk category. And we use a combination of about 12 risk criteria to put providers into each one of those categories based on their attestation information. For example, one of those 12 criteria has to do with Medicaid program tenure. So if the provider has been in the Medicaid program and has been active in the Medicaid program for a longer period of time, we feel like they are less risky for an audit. So they would receive a lower score for that specific attribute, whereas someone that's new to the Medicaid program would have a little bit of a higher score in terms of that criteria. Then what we do within each one of the categories, low, medium, and high, is we alphabetize the list of providers within each category and then do random selections. And we do select a little bit more providers or a higher proportion of providers in the medium and high buckets than we do in the low buckets. But it is a random selection process within each one of those categories. So it's also important to mention that we're doing several types of audits. To date, we've done program year 2011 audits, which have been focused on the adopt, implement, and upgrade, or AIU audits. And they've all been desk audits, which is a remote audit that we do over the phone and email and through DSM. This year we'll be starting, and we're launching program year 2012 audits, which includes AIU as well as now meaningful use, or MU audits. We believe that the majority of these will be conducted as remote desk audits, but there may be, and this is at AHCA's discretion, a need to do some on-site audits as well. You'll see throughout the theme, I'm going to turn it over to Sarah in a minute to go over some more of the details around our audit procedures. But you'll see a theme about an auditable data source, and we'll talk about, what really are the expectations of AHCA and KPMG to see from the providers during this process. And it really goes back to, if you're using a system-generated report to complete your attestation process, it's really around documentation retention at the time of attestation. So there's a requirement to to retain the documentation for 6 years. So it's very important for providers to save this information and retain it in a safe place in the event that you're selected for audit. So you'll hear that theme kind of throughout the presentation today. So with that, I'm going to turn it over to Sarah, and she will go over the audit process.
Thanks, Chris. Good afternoon, everyone. As lead audit staff, I've had the pleasure of working with AHCA over the past year in conducting the first round of audits. So as Chris mentioned, I may have spoken with some of you in the past, and in the event that you are one of the lucky chosen ones to be audited for program year 12, then you may be speaking with me as well. I'd like to start with an overview of the audit process and then provide you with some more details about what to expect during that process. So the process begins with selecting the auditees, and Chris has just briefed us on a little bit about our risk assessment process and how we go about selecting our sample. The next step in the process is notifying auditees and sending out our information request list. And we do want to focus a good bit of time during this presentation on that step and give you some good information around the kinds of documentation that we are going to be requesting and that you should be maintaining in the event that you are audited. We then review the supporting documentation that you would provide, and the objective of our audit procedures is to verify that the eHR program requirements have been met. At that time, we would identify any findings or observations and report those to AHCA. AHCA may then communicate those results to you. And we are currently in the process of selecting auditees for program year 12, and we plan to send out audit notifications this month. You would first receive a notification letter from AHCA, and then KPMG will follow up with our own notification letter and our information request list. We are giving providers 15 business days to provide the requested documentation. And I do want to emphasize that the documentation should be provided to us securely. We recognize and respect the confidential nature of the information that you're providing to us. And so with that in mind, the audit notification letter that you'll receive from us does lay out the various methods that you can send information to us, but the preferred method of receipt, particularly for the patient volume information, is electronically through AHCA's direct secure messaging service. And you can sign up for DSM for free, and I'm sure that Kim, as well as others in the program, would love to share with you how to do that. As Chris mentioned briefly, for program year 12, we will be auditing both providers who applied for year 1 or AIU payment, as well as those applying for year 2 or meaningful use payment. So for those of you who may have come in as a year 1 in program year 12, we want to make sure that we give you the opportunity to call us if you have any questions about the requested documentation or the audit process. For those of you coming in as a year 2 in program year 12, we are actually scheduling an introductory call just due to the increased complexity around meaningful use. We will be sending out our audit notifications at one time, so don't be alarmed if you send in your documentation and you don't hear from us for a bit of time because we are working through a queue of auditees, and we will be completing the audits on a first-in, first-out basis of information received. For year 2 auditees, we will also be contacting you with a follow-up request list after our initial review of the initial documentation provided. And again, you will be provided another 15 business days to respond to that follow-up request. which brings us into source documentation. And CMS requires that providers maintain an auditable data source to support their attestation. And you may be wondering exactly what do you mean by auditable data source. And basically what that means is a report that's generated out of a system that can be reconciled to your eHR system. So an example of a sufficient auditable data source would be a report of encounters for each patient out of your billing system versus something that would probably not be considered an auditable data source would be a scanned PDF of appointment logs where the insurance carrier was handwritten next to each patient name. So you can see how we need to be able to verify that the program requirements have been met, and it's easiest to verify when it is system generated. So as Chris mentioned earlier, CMS does require that you retain documentation for 6 years, and if you did not use your system, say if you're coming in at AIU, then you need to maintain the source documents that demonstrate how the data was accumulated and calculated. And I do want to emphasize the need to save screenshots, particularly for meaningful use, that you use during your attestation. And an example of that is Core Measure 2, which is drug-to-drug interaction. The CMS requirement is that you demonstrate that those drug-to-drug and drug-to-allergy checks were implemented for the entire eHR reporting period. So it's very difficult to prove that it was implemented during the eHR reporting period if you have not maintained a dated screenshot. Okay, and that moves us into a little bit more detailed discussion about the information requested for AIU and meaningful use audits. So let's start with AIU. And a new item that we're requesting this year is a listing of group members. And this would apply to those of you who attested to group volume. And we want to see a list of the group members that you included in your group volume. The next two bulleted items are really the core of the AIU attestation. The first one being patient volume. We are requesting patient-level volume reports, and we need those reports to contain a number of key data elements. These include patient name, patient date of birth, rendering and or billing provider, date of service, amount paid, and primary, secondary, and tertiary insurer billed. We are sending out a patient volume report template this year that will have all of those data elements, so hopefully that will clarify exactly what we're looking for this item. And lastly, we are requesting the eHR certification and proof of purchase. And proof of purchase can take on a number of forms. Acceptable examples are an executed contract or a paid invoice, anything that essentially proves that you did purchase the system. You may be asked to provide additional documentation if you attested as a PA-led or as a QHC or RHC. So there are some additional requirements that do apply to you. Then for the meaningful use audit, you will be requested to provide all of the same information as AIU and some additional fun items as well. So the second bullet on that list is report a total unique patients during the attested period. We will also be requesting meaningful use reports. And what we mean by that is if your system has a meaningful use dashboard that pulls information directly from the system to verify meaningful use, we want to see that. However, if you don't have a meaningful use dashboard available in your system, we need to see support for the items that you attested to, specifically support for each numerator and denominator. We also need to see support for any exclusions claimed, and what we mean by that is a report from the certified eHR system that shows a zero denominator for the measure or otherwise documents that you qualify for that exclusion. And in our information request list, we detail out by measure the specific documentation requested. So on this call, I'm not going to bore you with every single one of them, but I do want to provide you with a few examples of what we're looking for. And basically what the core and menu measures boil down to is we need to see support for each numerator and denominator, and oftentimes we will be requesting a screenshot to substantiate the measure attested. An example of an exception to that is core measure 15, which applies to the security risk analysis. In that instance, we are requesting a letter or a detailed document demonstrating that you conducted a security risk analysis and took corrective action on any identified deficiencies. Another example for core measures is for core measure 1, we are requesting dated screenshots demonstrating that 2 of your patients had their medication entered through the eHR system. And then I just pulled an example for a menu measure as well. Menu measure 7, which pertains to medication reconciliation. We're requesting that documentation supporting that medication reconciliation was performed if you receive a patient from another setting or another provider. And then additional support just for the clinical quality measures as well. For program year 12, there aren't a lot of requirements surrounding CQMs, but we just need to see support for those. So that's a more general request. I'd now like to turn to our audit progress to date. And as of the end of May, we have completed 70 audits for program year 11, and we only did AIU payments for program year 11. We had 7 findings and 25 observations. And just to give you an idea of the difference between a finding and an observation, a finding is similar to an observation, but it's a little bit more stringent. It results in a deficiency in meeting a program requirement, and it may result in a recoupment. Versus an observation represents a reporting or calculation error or a lack of documentation that does not constitute a deficiency in meeting a program requirement. It's something of note that we want AHCA to be aware of. You can see that in the pie chart, AHCA had $56 million in program year 11 AIU payments. We audited about 2% of those payments, and when you extend that to the group payment value directly related to those audited payments, we audited the group volume equivalent to another 19% of the AIU payments. And we plan to conduct a similar number of audits for the remaining program years. all of our findings and observations for program year 11 pertained to patient volume, and I wanted to just highlight some of the key themes that we noticed from program year 11. We had some providers that did not meet the 30% patient volume requirement, and that may have been the case because of not fully understanding the definition of an encounter. So then when we recounted based on the definition of an encounter, they fell below the 30% threshold. We had some providers attesting using number of patients or procedures rather than encounters. And so just wanted to reinforce that the definition of an encounter is services rendered to an individual on any one day. Another theme that we noticed was some providers included claims that were not paid by Medicaid in their patient volume. And per the Stage 1 final rule, claims for which Medicaid did not pay any portion have to be excluded from the numerator. And sometimes there again, that could cause the provider to fall below that 30% threshold. We also had a few providers who did not maintain an auditable data source to support their patient volume attested. And where we noticed this was some providers were not able to access the original system that they used for their attestation. And then we also noticed a couple of observations around group volume. We had some providers attesting to group volume who reported patient volume inconsistently across the group. And we also noticed there were a few instances where providers limited the group patient volume by excluding a location. I'd now like to turn to some of the challenges that we came across during program year 11. And these challenges can be mitigated by retaining the documentation that you use to complete the attestation. So I'll just walk through these and give some examples. The first one is documentation provided did not agree with the attestation. And this commonly occurred by a lot of the providers seem to retain summary level information used to prepare their attestation, but because it was at such a high level, when they tried to go back and pull patient level reports for us, they couldn't get back to the same numbers that they attested to. So just want to emphasize that it's easiest if you retain the documentation in detail at the time that you attest. And the second one here, we had some instances where the documentation was not provided within the deadlines, and when we sent follow-up questions, those were not responded to in a timely fashion. And this slows down the payment process as well for you if you do not respond timely to the request, because AHCA does delay the payment of future program years until the audit is closed out. The next one, a lot of times we received multiple versions of patient volume reports, and I think this can be best alleviated if you focus on making sure you send the 90-day period that you attested to. Oftentimes we received another period that didn't match the 90-day period that was attested to. And lastly, billing information supporting patient volume figures was no longer available through the billing service provider, which you can see how that would be a problem. So again, just want to emphasize retaining that documentation in detail that you use to complete your attestation. this time, I'd like to turn it over to Chris for a quick recap.
Thanks, Sarah. So just in summary, we talked about the program nationally and within Florida. We've kind of summarized the audit approach, and Sarah went through some of the details around the audit process and expectations. Again, if you're selected for an audit, there'll be a plethora of information that we'll send to you at the forefront of that audit notification process that will give you more details on the information that's requested. We went over some best practices and the information that we look at when we're conducting our audits. So hopefully it provided you with a better understanding of what we're looking for and what information to save during your attestations. And we talked about what we've done so far in terms of our audit progress and some of our results to date. So hopefully that gave you a little bit of a perspective of what some of the challenges that we're faced with in provider data. And at this time, I'd like to turn it over for Q&A. Or Kim, do you want to take back control?
Thanks, Chris and Sarah. Yeah, I'll just kind of jump in and just kind of reiterate some of the things that y'all said. Documentation, that's one thing that we really stress every time we have an opportunity to talk to our provider community, is really the key. And never hit that attestation or that submit button until you're sure that you have all of the documentation that may be necessary to support what you're saying is true in your application. Also want to make a plug, thank you, Sarah, for DSM. That is our direct secure messaging. If you are selected for an audit, I really do encourage you to take advantage of signing up for DSM. It really does facilitate the sharing of those documents. Depending upon what is being audited, it could be substantial. It just really saves you a lot of time and trouble on your end being able to attach everything electronically, communicate electronically with the auditors versus having to stop, make copies, mail them, or however else you would like to be able to send that information. So let's go ahead and open it up for questions. Operator, we do have about 10, 15 minutes for questions. If you're not comfortable asking your question online, you can always submit it to us through the HIT inbox. We'll be glad to route them to the appropriate people as well. So, Operator, do we have questions?
Once again, to ask a question, to press star, then 1. And please be sure to record your first and last name. One moment.
And while we're waiting on that first question, we have had a request for a copy of the presentation. That, as well as a recording of this webinar, will be available on the website probably within the next week. It takes just a few days to get everything kind of formatted. Any questions?
Okay, we do have one question on the phone. Ms. Delgado, your line is open.
Yes, good afternoon. My question is about one of the reports that Sarah said that we have to have is all the claim has to be paid by Medicaid. I have a question. In the case of our patients that have secondary insurance as Medicaid and primary are Medicare, for all that claims, Medicaid never pay because the fee schedule for Medicaid is lower than the fee schedule for Medicare. My question is, we can count that patients in the patient volume for Medicaid or no?
All right. I believe the question is for those patients who have both Medicaid and Medicare, do they count in the patient volume even when Medicaid may not come in and pay additional monies? Is that correct? Is that your question?
Yes.
The answer is yes. We've always allowed, and the rule always allows for you to count what we call dual eligible, so it's for Medicaid and Medicare. And then this year, of course, with the change in the volume requirement, anyone who is Medicaid eligible on the data service is able to be included in your volume regardless of whether or not Medicaid paid any towards that claim. So
Okay.
yes, your dual eligible should be included. Documentation, is going to be a different issue, so just be sure that you have the documentation to back up that they were both Medicaid and Medicare eligible on the date of service.
Okay, perfect. Thank you.
There are no further questions at this time.
Okay. Well, I hope that you found this helpful. One of the things that we have learned is there's a lot of questions when audits happen. Again, our intent is to make sure that you have the information that you need. As I have said earlier, both the audio and a copy of the presentation will be available on the website so that you can refer back to it, share it, and we can all use it as reference. And in the meantime, if you do have questions about the audit process, feel free to drop us a line at the Medicaid HIT inbox. And then if you are selected, if you're the lucky winner and are selected for an audit, then of course your communication avenues are explained in the letters and such that you get from either KPMG or from AHCA staff. Thank you, KPMG, and all the people who signed on today. And if there's no further questions, then we'll conclude the call.
Thank you for allowing us to present.
This concludes your conference call. You may now disconnect.